Okay, hello everybody. My name is Laura Crane and I'm really delighted to be able to welcome you to this event as part of our CRAE webinar series. For those of you who are new to CRAE, and as a refresher to those who are more familiar with us, CRAE is the Centre for Research in Autism and Education, which is based at University College London in the Faculty of Education and Society. And CRAE comprises a team that includes both autistic and non-autistic staff and students. And the goal and ethos of our work is to conduct really high quality research, but importantly to aim for that research to be on topics that really matter to autistic people and their allies. And crucially, that also really meaningfully involves the community in designing and developing and conducting and sharing the work we do. So it's all about taking a very participatory approach in everything we do. And we're also very committed to making sure that research and knowledge linked to autism is shared beyond academia and that everyone can engage with our work and as well as other people's work in a really engaging and accessible way. And that's one of the reasons that we set up this CRAE webinar series, so that we could showcase the work of some of the leading autism researchers, practitioners and advocates in the field, and to do so to an audience that includes but also transcends academia. And at this point, I just want to say a particular thank you to all of our funders, supporters and team members who work really hard and are able to make these events possible. And a special thank you to the Pears Foundation, who really generously support our work and without whom these events really wouldn't be possible. So that's a bit about our centre and our values, and I'm absolutely delighted now to introduce you to our speaker for today's webinar, who is the phenomenal Aimee Grant. Aimee is a senior lecturer in public health at Swansea University, based within the Centre for Lactation, Infant Feeding and Translational Research, or LIFT. Aimee is autistic, disabled and a wheelchair user, as well as being from a working class background. And Aimee notes how these experiences leave her with a strong desire to promote social justice and to challenge inequality, both within their research and teaching. Aimee is an author who's written 2 books on doing research with documents. And Aimee is also the recent recipient of a very prestigious 8-year Career Development Award from the Wellcome Trust, which is entitled Autism from Menstruation to Menopause. And this is a project that will use creative and participatory methods to understand the reproductive health experiences of autistic people with wombs. And I actually learned about this project after being invited to review Aimee's grant application. And when I read it, I was just absolutely blown away by how brilliant it was. And it's genuinely one of the most exciting and innovative and important autism research projects that I've ever seen. So I'm really looking forward to see it get started. And I'm so pleased that Aimee has agreed to speak at one of our events today to share their work with our CRAE community. So on that note, I'm going to hand you over to Aimee now. And just to add to our attendees that you're welcome to put any questions for Aimee in the Q&A box on Zoom. And you can also do this anonymously if you wish to. So thank you again, Aimee, and we really look forward to your talk on autistic experiences of pregnancy loss and associated healthcare.
Thanks so much, Laura. So yes, as Laura's explained, I'm going to talk to you today about autistic experiences of pregnancy loss and the healthcare that goes alongside it. If you want to tweet along, you're very welcome. My Twitter username is @Dr. Aimee Grant. And let me move the slides on. Okay, so before I get into the detail, today I'm going to cover a little bit of background about what pregnancy loss is and what we know about neurotypical or mostly neurotypical people's experiences of it. I'll then talk to you about clinical guidance. So in the UK, that's NICE guidance. And I'll then talk to you a little bit about my own experiences of pretty horrific care that moved me into this area of work. The data I'm going to show you today is from a survey of UK autistic people who had been pregnant, and 66 of those told us about their experiences of pregnancy loss. So I'll tell you a little bit about their experiences, and then I'll bring my conclusions from their own recommendations for what healthcare should do better. So thinking about pregnancy loss as a phenomena, it's divided into early pregnancy loss and later pregnancy loss. So early pregnancy loss is anything that occurs in the first 13 weeks of pregnancy. And that accounts for between about 15 to 20% of pregnancies. So we're thinking of up to 1 in 5 there. And as people get older, their risk of having a pregnancy loss increases. So every kind of 5 to 10 years, you see a jump in the prevalence of pregnancy loss at an early stage. And so people over 45 years of age, 4 in 5 will experience a pregnancy loss every time they get pregnant. And thinking about this on a global scale, 23 million miscarriages occur every year. So it shows that actually this is a really big issue affecting the lives of women and other people with wombs. Miscarriage is the most common type of pregnancy loss, but it isn't the only type. An ectopic pregnancy is another kind of pregnancy loss. And that's where the embryo embeds itself somewhere other than the womb, so in a fallopian tube or somewhere else in the abdomen. An ectopic pregnancy is the leading cause of pregnancy-related mortality globally. And the rates of mortality seen really vary depending on the healthcare system that's in place. So where there are more developed healthcare systems, we see lower rates of mortality. But regardless of that, 2/3 of deaths from ectopic pregnancy come because of poor medical treatment. So we're having opportunities missed, and that's then leading to more serious complications. Thinking about the literature on pregnancy loss, prior to my survey, there wasn't anything that was exclusively related to autistic people's experience in the peer-reviewed literature. But looking at the experiences of a general population of women, because all of these studies have been focused on women rather than minority gender identities, we see problems from start to end. So first of all, we see women being turned away from services when they're actively miscarrying. So when they're bleeding quite heavily, in quite a lot of pain. And that is really, really upsetting and distressing. Also, often when you present to healthcare services, they will do some tests, and then typically they'll send you away for up to kind of 2 to 7 days before they ask you to return for further tests. And that waiting period where you don't have any interaction with the healthcare service is known to be incredibly stressful and anxiety inducing. If we think as well that many of the people experiencing these symptoms will be in early pregnancy, so the first 3 months, and they may not have told friends and family, they may well need to go to work still because they haven't told their employer. So it's a really difficult time. One thing that has been found helpful at this time is the use of ultrasounds. So that's either a trans-abdominal ultrasound, so the sort of thing you see on TV when someone's pregnant. They roll up their top, put some jelly on the tummy, and then put a wand over the tummy. Earlier in pregnancy, it's quite common that ultrasounds are delivered vaginally. So you have quite a long, skinny probe that's covered in something that looks very much like a condom. and that's put into the vagina so they can then angle it closer to the uterus and the fallopian tubes. So when the visible signs of pregnancy would be smaller, it's easier to see in that way. So women have said that having those ultrasound scans, being shown on a screen that actually their pregnancy hasn't developed normally, or there isn't anything visible that can be seen, is really helpful to reassure them that they are losing the pregnancy. Alongside this, though, goes a lack of information given by health professionals. So, for example, if you're being sent away between tests, you might not get any information about what is normal to expect and when you should be considering that you're having a medical emergency and you need to go back. So, you know, we have some good things and some bad things when women are outpatients. When people are moved into hospital, so onto hospital wards, this has been found to be almost entirely universally distressing. So often people losing their babies will be on wards with pregnant people suffering other complications of pregnancy. So for example, people with very severe vomiting that might need to be on intravenous fluids will be in the bed next to somebody losing their pregnancy. A lack of sensitivity among staff just across the entire board of care has been identified. But it gets worse at the point where women are told that their pregnancy will not be viable. And that kind of consideration that the person was hoping that that would be a viable pregnancy seems to be lost. So it's not really considered as a loss of life compared to, say, in services like oncology, where a lot of care is taken around facilitating that loss of life. And that can include a lot of women reporting that they were told when they were by themselves that their pregnancy wasn't viable, and just having to suffer through that alone rather than allowing a partner, a friend, a family member in to support them. With all of those really negative experiences of healthcare, it's completely unsurprising that in the long term, people that have experienced pregnancy loss have a lot of guilt around the pregnancy loss, so concerns that they have done something that may have resulted in the pregnancy loss, when the most common situation is actually that there were chromosomal abnormalities, that the fetus would never have been able to have been born and lived, and therefore the uterine lining rejects the implantation of the fetus. So the body does a lot of stuff to protect women from pregnancies that they know aren't going to be viable, but that isn't explained. When people who've suffered a pregnancy loss go on to have a subsequent pregnancy, we know that they have really high levels of anxiety, and that goes through the pregnancy all the way up to birth, thinking that that baby may also be lost. In some cases, that even goes into that baby becoming a child all the way through their early schooling, with feeling like that baby might die at any moment. So it's really, really impacting on women's mental health when they go on to have further pregnancies. Oops, excuse my reminder there. So then, moving on to think about the clinical guidance for how pregnancy loss should be treated. We see really common clinical guidance in the UK, America, Canada, Australia. So in the kind of the big developed healthcare systems, there are these pieces of clinical guidance that anybody can see on the internet. They all have quite similar content, so the blue and green boxes in the middle of the screen, but something I want to draw your attention to first is the pink box. So NICE, which are the English clinical guidance, which tends to be adopted quite a lot around the UK as a whole, say that patients should be treated with dignity and respect during pregnancy loss or treatment for suspected pregnancy loss. And that's something that I think really sticks with me. But as we go through, we'll see there are a lot of barriers to that happening. So in the UK, starting on the top left, we have specialist early pregnancy units. So NICE said that it was really important for expertise to be pooled. So when medical emergencies like ectopic pregnancies happen, you have that expertise in a centre. Moving across then, all patients that present to an early pregnancy unit or wish to be referred to an early pregnancy unit should be reviewed within 24 hours of referral. And those referrals can come from primary care, so GP surgeries, and also from emergency departments, so your accident and emergency, casualty departments. Moving to the bottom left box, then we see that diagnosis of early pregnancy loss is through transvaginal ultrasounds. So that's the ultrasound through the vagina, and also blood tests. So the blood tests are measuring for beta HCG serum, and that is a hormone in the blood that the more pregnant you get, the higher the level of that serum in your blood. So it's what your urine dip pregnancy test is measuring. And the more pregnant you are, the higher it goes. But also then if your pregnancy ends, so even if you haven't fully miscarried, the rate of the HCG serum will decline. So in the UK, it's recommended that you have a blood test on day 1, and that would be repeated 48 hours later, so on day 3, to see if there's been an increase or decrease over time, and that those two results together can give a very clear picture of whether a pregnancy will be viable. Moving on to the bottom right, for people experiencing the most common types of pregnancy loss, so miscarriage and ectopic pregnancies, there are 3 forms of management. So expectant management is that thing that we've seen from the research that really stresses out patients. So you go in, you have a scan, you have a blood test, and then you're sent away for somewhere between 2 and 7 days before you come back and have tests repeated. And the idea there is that people might naturally miscarry, and we don't want to carry out interventions that can have quite serious side effects without there being a very clear need for them. The second form of management is medical management. So that's when you know that the pregnancy won't be viable and the person is given some medication, so really quite nasty toxic drugs that will make them miscarry. And they're the same drugs that are used in medical abortions. And they vary depending on the type of pregnancy loss you're having, but they both aim to force the uterus to contract and expel the pregnancy contents. And then third, we have surgical management. So for a miscarriage, that would be through the vagina to just remove those products of pregnancy. And for an ectopic pregnancy, that would be doing laparoscopic surgery, so keyhole through the abdomen. So we've got this very clear guidance for what should happen in the UK, and it should all happen with dignity and respect. And patients should also be given verbal and written information at all times. So let's move on to show how that's really happening in practice. So, oh goodness, I've got a green box in the middle of my screen that shouldn't be there. Please ignore that. So the reason that I moved into considering what autistic people's experiences were like was because of my own bad care that I received for an ectopic pregnancy in 2020. So on a Sunday, I phoned my midwife and got a phone number from her voicemail that I should phone. I phoned that, I got through to the hospital. They told me to phone the early pregnancy unit. So it was the first time I'd ever heard of that. And I spoke to somebody there who said that they couldn't do anything for me because I hadn't been referred by my GP. I needed an appointment with my GP. Now, it was a Sunday. Anybody living in the UK knows how difficult it is. So you can go to out of hours GP kind of centres that are located in cities mostly, but you have to phone and then you have to wait to talk to someone to be invited in. It's not an easy way for anybody to access care, let alone somebody who might find it difficult to make lots of phone calls and advocate for themselves. I told the person on the phone I thought I was having an ectopic pregnancy. I'd read up on the symptoms. I was in excruciating pain, and they said to phone my GP the next day. So I then started being a Google doctor and found a private clinic, and I could get a scan for that day. And I should say I had a meltdown after that first phone call. I phoned to book myself in for a scan and told them I thought I had an ectopic pregnancy, and they managed to get me in quite soon. I arrived there and I was sat in a waiting room with 3 people with big happy bumps that were all going for their 4D scans, and they were running an hour and 40 minutes late. So that led to meltdowns 2 and 3, so going outside to wait. So that was the first meltdown. I went and had the scan. The sonographer didn't talk to me. The person that worked on reception told me what the sonographer had found. I don't think she was medically qualified. And I was told that I needed to get in touch with them the next day if I still had a positive pregnancy test. Now, I had a very solid line on my pregnancy test that day. I knew I would still have a positive pregnancy test the next day, but I just went along with what they said. The next morning at 7:30, did my pregnancy test. It was still very, very positive. I wasn't able to speak. I was having a shutdown, so I sent them an email, and that kind of just got lost. So nothing really happened until I was phoned by the clinic at about 2 o'clock, 2:15 that afternoon. Bearing in mind this is a medical emergency and people should be seen within 24 hours according to NICE, and the person said they'd passed on my case to the hospital. As soon as I put the phone down, I was phoned by the early pregnancy unit, and the midwife told me to come as soon as you can and before 3 o'clock, which was in 45 minutes, so showing that urgency picking up. Before I was admitted onto the ward, I had 5 outpatient appointments. So that was going into the clinic, having a scan, having a blood test, sitting around and waiting for several hours each time to have a doctor review my results, and then being sent home again. So when I first presented to the early pregnancy unit, I rocked up in my bright purple electric wheelchair. I very clearly look, like I could be neurodivergent. I have coloured hairs. I have big colourful tattoos. I struggle with eye contact. And I told the midwife on the door, or the nurse, sorry, that I needed to have my husband to help me communicate in the appointments, but also to take notes for me. So I'm dyslexic as well, and my working memory really struggles. And I was told an absolute 100% no. So we were in the COVID kind of lockdown sort of periods around then, and the hospitals were being careful to try to manage COVID risks. So I understand why it happened, but it wasn't an easy thing for me to manage. Across those 5 appointments, I think I had to give a urine sample every time when I arrived, and I was directed into a toilet that had a wheelchair sign on the door, but it wasn't big enough to get a wheelchair in it. When I was admitted to the ward, about 10 metres down the corridor, there was a fully accessible toilet. I don't know why they wouldn't let me use that, but that was really difficult to manage every time. And then between the tests and seeing doctors to give me the advice as to what should happen, so if I go home, if I need medical or surgical treatment, I was sat in a very small waiting room. you know, maybe 3 meters square with lots of other people, and it was loud. There were bright lights, there were close to floor to ceiling windows. It had quite a high ceiling, and there were lots of people in that room that were pregnant, and that then led to some really difficult times. So I actually started taking field notes on my phone during that point to try and block out everything around me. So I pretended I was there to do a medical ethnography because that's part of my day job, and I needed a way to escape the situation. So I went in and had my first transvaginal scan and was told then that I almost certainly had an ectopic pregnancy, but that they weren't entirely sure, but the pregnancy wasn't viable. I was then sent back to the waiting room for 3 hours before I got any pain relief or could see a doctor. And there was somebody in the waiting room who didn't really understand social convention and also didn't have a very good understanding of pregnancy loss. And they told me, don't worry, your baby will be okay, after I'd been told that I was definitely not having a viable pregnancy. And shortly after, I noticed that I hadn't put my blue badge, so the UK disability parking permit, on the windscreen of my car in the hospital car park. And I thought, this is the last thing I need. I'm going to get a huge fine. I don't know when I'm going to be able to leave. And that was it. I had a really big meltdown. I went out of the waiting room to reception. Nobody was on reception, and I wanted some reassurance that they would be able to stop me getting a parking fine. And with hindsight, you know, that wasn't really what I was thinking about. I was really upset that I was losing my baby, and that this insensitive woman had been repeatedly telling me I would not lose my baby, it would all be okay. But basically, I spent about half an hour in the corridor near reception before anybody gave me any help. So a cleaner refused to help me find a nurse. I asked a doctor if they knew how long I would need to stay because I was having a full meltdown. I really needed to leave, and she told me she had more urgent patients she needed to deal with. And so then when I eventually saw a healthcare assistant and told her that I would have to leave if I wasn't able to see my husband, they then agreed I could sit in a private room by myself that they'd had all along, but just hadn't considered it important enough for me to use. As well as declaring that I was autistic on arrival, I'm quite medically complex, and I have a 1.5 A4 pages handout that I give when I go into hospital, that outlines all of my diagnoses, you know, and the various allergies I have, and my consultants' phone numbers. And so it was very clear to the doctors and the nurses that were treating me as well that I was autistic, but they just hadn't considered that. Eventually, it was decided that if I was going to go home, it would be better for me to sit in this horrible old corridor that was cold and dark and had some really noisy lifts in it than to leave entirely. So my husband was allowed to come and sit in the corridor with me. He had recently broken his leg and he wasn't given a chair, so that wasn't very good. And then when I eventually got to speak to doctors, there was no effort made to ensure that my husband could, you know, phone into those conversations. So again, I was sat just trying to take notes on my phone to remember what had happened. Moving into the inpatient stay, I was put on a 10-bed ward with up to 8 other patients. It was loud and bright, and for most of the time I was there, I was the only person suffering a pregnancy loss, and that led to a lot of meltdowns. Far from ideally, my ex-boyfriend ended up being an anaesthetist who came to see me at my bedside, thinking he would offer some comfort when it really wasn't the ideal time. Nurses came in wearing a lot of perfume when I'm really allergic to fragrance. And it just constantly led to me going and locking myself in toilets to literally just stim and re-regulate to be able to cope with sitting in my hospital bed. I eventually had the surgery for the ectopic pregnancy, and not long after I had an allergic reaction, so 2 nurses had very strong perfume. I tried telling the nurse in charge of my care twice. She didn't quite understand, and I just had to self-discharge. And then at my 7-day checkup, I was told off by the senior nurse who'd been on the ward for doing that, rather than acknowledging all of the systemic things that led up to me needing to self-discharge. And she also then didn't look at my my surgical wounds that I was concerned about. And she also then wouldn't give me information on things like when it would be safe to have sex again after having that kind of invasive surgery. So it was all really, really horrible. And I then started reading the literature, and I was like, surely it's not only me who's had these experiences. So moving on then, I developed a survey for people who'd been pregnant and were autistic from the UK. And we had just shy of 200 participants, 66 of who told us about their pregnancy loss. So people were able to skip that section if it was too sensitive for them. Around half were diagnosed as autistic, a quarter were undergoing diagnosis, and a quarter were self-identifying. And as a whole, it was quite a privileged group. So 85% preferred to speak, 85% were cisgendered, 91% were white, and 58% were educated to at least degree level. But there was one thing that really stuck out for me, in that 3/4 were disabled in addition to being autistic. So something separate to being autistic, they classed as a reason for them being disabled. And I asked them a series of questions, closed questions with a 5-point scale for their answers around general challenges in accessing healthcare. And I've coded these where people have said, so green is that below half of people said that this always or most of the time happened for them. Orange is half to 3/4, and red is above 3/4. And just looking at the colours on the slide, you can see actually accessing healthcare was really difficult for our group of people who experience pregnancy loss. So awareness of pain and injury was something that was difficult for people. And then when it came to trying to get treatment for that pain or injury they'd identified, for over 3/4, there was a delay in seeking treatment, feeling anxious when phoning to make a healthcare appointment or for a telephone appointment itself. And that led to delays in making telephone calls to healthcare. So all of those are really relevant to people experiencing a pregnancy loss, because it is really time sensitive. And then thinking about what happens in the waiting room, between half and 3/4 said that the sensory environment in the waiting room made them anxious, and also that other patients in the waiting room made them anxious. So we've got all of these challenges before you get to see a health professional. And then moving on to when you're actually there in the presence of a health professional, just below half, so only one more person would have pushed us up to the 50%, said that, you know, we had frustrations and misunderstandings when talking to health professionals, you know, so we're still over 40% saying that. And almost everybody said that they masked in healthcare settings, so that's taking a lot of energy. Over half said it was difficult to describe pain. And then we're just under half again said that it was difficult to understand health professionals. And so that's really important when we're thinking about information given during pregnancy loss, especially if you're sent away for that watchful waiting period. Moving on to think specifically about their experiences of having an early or a pregnancy loss in general. Most were early pregnancy, some were later on, such as stillbirths. The only cross-cutting theme was trauma. So almost universally, participants reported it being traumatic. Sometimes that was associated with poor healthcare experiences, which I'll talk more about shortly. And 7 people reported that they had increased meltdowns and shutdowns during their pregnancy loss. And this comes from the open text data. So I think more people may have experienced that, but we didn't have closed questions with tick boxes for this. One person said that they became suicidal because the trauma was so great. And another said that they wouldn't seek medical advice in the future for pregnancy loss because it was so traumatic. And I've just taken out some quotes on the bottom of the screen that represent the sorts of things that came through in relation to trauma. So the first quote says, "I didn't feel like I had enough information to cope." So NICE guidance says we need information, and that's not coming through. Moving across the screen, I was in a lot of pain, but didn't know how to explain or share this with others. So we're seeing that actually pregnancy loss itself, it is hard to describe, especially those early feelings of, is something happening or isn't it? But then when you're autistic and you struggle to describe your pain, that builds on top. On the bottom left, we see the uncertainty of what was happening within my body caused both shutdowns and meltdowns. No one could be sure I was losing the baby, and so I was sent home to wait for another scan. You know, so we've got these really, really difficult things happening that are increasing meltdowns and shutdowns completely understandably. And lastly, somebody said, no support was given for the traumatic event. I felt abandoned and alone. And we had a lot of that holding the weight of a pregnancy loss to themselves. And that's common in the general population literature on pregnancy loss. But actually that really feeling like you're alone and you're not able to communicate about it and support is not accessible can really add to that. So moving on then to thinking about why people sought care for their pregnancy loss or they didn't. And these again come from the open text questions. So 10 people talked about not seeking care. And that was split between expecting to receive bad treatment, as you can see in the first quote on the page. So I feel as though I would be judged for having a less emotional approach to things than other people. So we had people saying that they didn't identify with losing a baby, that, you know, to them it was still very early, it was a bundle of cells, and the health professionals just couldn't understand that and actually kind of disengaged from being supportive because of this more compartmentalized emotional response that some autistic people had. And then other people had had previous trauma from their care for pregnancy loss, which meant that they didn't decide to seek treatment in a future loss. So the second quote says, I felt belittled and ridiculed for being in pain. The miscarriage I had after I had at home. I will never involve them unless it's an emergency. And I have to say that's exactly how I felt. And, you know, these themes of, you know, I've had an awful time, I can't possibly cope with that again, came through the data. And then 11 people wrote about their seeking care. But for 6 of these, this happened because they went to a routine scan or a routine appointment, and their pregnancy was considered to be at risk of being lost. So the third quote says, it was a routine scan and they couldn't find a heartbeat. I then had to go back the next week to check, and then the following day for it to be removed. So we're seeing that things aren't happening quickly here. We've got this watchful waiting. 4 participants said it was a medical emergency, and they really didn't have any opportunity. So the 4th quote says, "I started bleeding and was advised to go to A&E." So this person spoke to NHS 111 first because they knew they had to do something, but they weren't sure how serious it was. And then 2 people talked about seeking reassurance before they took it to the NHS. So the bottom quote says, "I felt like something was not right, so I booked a private scan." So we see actually the use of things like private scans, phoning NHS 111, maybe phoning a midwife. All of this is happening before you move into the early pregnancy unit. So we've got multiple hurdles for autistic people to get over, perhaps with telephone calls, needing to describe their pain before they're moving into being given any detailed support or treatment. Moving on then to experiences of receiving care for pregnancy loss. This was almost entirely negative. That there was very little good in the data. So negative experiences focused on communication for 18 participants and the support that was received for another 18. And these are both spoken to in the top quote. So my daughter was stillborn. I was so overwhelmed that situational mutism would take over, and a lot of my decisions were made for me because they were rushing. And that's that medical emergency thing again. At one point, when I gave birth, they didn't believe I had delivered due to the lack of pain I was exhibiting. So not having those neurotypical pain presentations meant that until this participant shouted at them to look and move the sheets off me, nobody believed that she had pretty much delivered the baby. And because of this, it was a horrifying time. 4 people talked about the hospital environment itself and how difficult that was for them to manage. So staying in hospital can only be described as sensory hell, being out of control of the situation, out of routine, unable to sleep, causing inevitable meltdowns. So these poor experiences again were considered to be overwhelming by 9 and led to shutdowns and meltdowns for 6. So the 3rd quote on the screen says, "Too much information and detail during my scan to confirm a miscarriage triggered a meltdown." So when information is given, actually it may still be too much and at the wrong time. So I remember being told or overhearing a consultant who was performing a transvaginal scan, so probe in my vagina, in my body, telling his junior doctor about various things, so that I had an empty sac. And that was the first time that I'd heard that there was an empty sac or a pseudo sac. You know, these things are not delivered with sensitivity. And during a scan, when you have that ultrasound jelly on your belly or a probe in your vagina, is really not the appropriate time to give that information. And lastly, we had 4 people who described good care. And that was nearly always associated with having continuity of carer. And so this person says, "I was lucky enough to be under the specialist pregnancy loss clinic in my last pregnancy. I saw the same person each time, and they were happy to answer all of my in-depth questions, which was excellent. I wish everyone could have that type of care." So we have that real acknowledge that we need our questions answered, but in a way that's appropriate for us, having that continuity of care, Having staff who have the time to answer questions is really important, and there's the acknowledgement that not everybody gets that care. So moving on then to consider what my participants thought should be done. So these were explicit responses to the question, what should be done to improve pregnancy loss care for autistic people? And they were mostly focused around staff rather than the broader hospital system. And that included using clear and direct communication, being more compassionate, which I think again leads to that bigger issue of staff having not enough time and too heavy patient loads. So we need more staff available to be able to enact this recommendation. We also need staff to have a better understanding of autistic needs. And again, that's systemic. We need training delivered by autistic people on autism, and that needs to be part of curriculums for doctors, nurses, midwives. And we also need to aim to meet autistic patients' needs. And these specific things came up. So we want partners or a family member, a friend to come along to be able to communicate on our behalf when necessary. We need answers to all questions, and I think that will go a long way to reducing trauma. The sensory environment should be improved. And again, that's basic things. That's putting people in a single bedded room where there is one available. And that's generally having more knowledge within hospitals of what needs to happen. And lastly, continuity of carer came through really clearly to avoid having to explain needs and communication styles and pain styles over and over again to different doctors and nurses throughout treatment. So thinking then about things that you guys here can do to learn more about this area. So there are some resources available. So the Maternity and Autism Research Group has recently been set up. I'm a member of the group, and we're hosting all resources that can be used to help support autistic people during maternity care, including pregnancy loss. There's the Autistic and Pregnant Parenting or Planning private Facebook group. So health professionals are welcome to join that group, and it's an excellent resource for autistic people who are struggling. There are people in that group that will be able to empathise with you or your patients. On the Tommy's website, there's a blog from an autistic woman called Rachel. And then there are also books that have content on pregnancy loss from Alexis Quinn and Lana Grant, so both autistic advocates. And then Petra Boynton, who isn't autistic, has written a lovely book called Coping with Pregnancy Loss that gives really good guidance on how to be supportive. And a lot of it translates to meeting autistic people's needs by, just making time for that compassion. As always, the Boing Boing More Than Words report and NDTI's It's Not Rocket Science are really valuable. So how you can make your hospital ward more accessible. And if you are a health professional, if you can bring that to the attention of ward managers, I think things like that would help other patients. So people with mental health conditions, with high anxiety, can really actually be supported by making the environment less sensorially aggressive. And then if you'd like to follow my research, I've set up a Facebook group for the fellowship that Laura mentioned in the beginning called Dr. Aimee Grant, Autism from Menstruation to Menopause. And I will have 4 research assistant jobs up for advert in around 2 weeks' time, and I'll announce that in that Facebook group, and you can follow my work on Twitter. And that's everything from me today. So any questions?
Wonderful. Thank you so much, Amy, for that really, really brilliant talk on, I think, such an important and understudied topic. And I just want to say as well, thank you so much, not just for sharing your own work, but also your experiences, because it must have been very difficult to recount, but I think it really powerfully illustrates, the need for change and some of the major issues that we have in that respect. If anyone has any questions, they're welcome to put them in the chat. But I have so many questions that I'll get us started. And one of the things that really stood out from your talk was something that you mentioned about your own experience when you said that the professional said they hadn't considered that you were autistic. And I was really, really interested in that and wondered what you thought underpins that. Could it be a lack of training? Could it be kind of those kind of long-standing, unfounded assumptions about autistic people and reproductive health and, perhaps not being in relationships and things like that? It just seemed to me that that was, a really quite surprising thing to hear.
Yeah, I mean, I think what probably didn't come out in my narrative is that it felt like chaos. There was one room where they could scan people, and that was also the room where they had meetings with patients about what next steps would be for treatment. So if you've got 6 people in the waiting room and only one room where you can do any tests or discuss any responses to those results, meant that everyone was sat in the waiting room for ages. It felt as though the doctors were very, very busy. I did have an advanced nurse practitioner did my first scan, and she had a very nice, gentle manner, and it didn't feel rushed. And then I think when I eventually got taken in for emergency surgery at about 11 o'clock at night, there was a really lovely male doctor who was on staff at that point. And he properly went through my cheat sheet of all of my stuff. So, I'm quite complex in terms of allergies. So an anaesthetists really need to know what anaesthetic I'm allergic to and those sorts of things. But even those 2 people who I felt really made time for me didn't ever ask anything about being autistic. And every time you had to ring a doorbell to get onto the ward, and I would always say, I'm autistic, can my husband come in with me? And they said no every time. And I have really severe hand pain, and so I wear a silicone wedding ring on my right hand. I can't wear it on my left hand, it hurts too much on that hand. And because I have lots of publications, I didn't take my husband's name when we got married. And I had a nurse say to me at one point, oh, so you're really, are you really married? And, my husband's a good looking man and he has a fancy job, so needs to wear a suit and tie. And, and so I would be dragging him out of meetings with, I really need to go to the hospital now, or the hospital have phoned and they've said I have to go back in now. And so he'd turn up looking really hot in a suit, and they'd see this person who had slept in the same pair of maternity dungarees for about a week because my stomach was so sore I couldn't have anything touch it. And they just couldn't put us 2 together. So I think, I'm a wheelchair user, so there's the ableism there as well. But I think they didn't have enough time, they didn't have enough space to treat people, so they should have had multiple treatment rooms. And I don't think they had any understanding of autism at all. I really don't understand how the nurse on my final day could misunderstand I'm having an allergic reaction, I need to leave. I don't know how that could be misunderstood, but I feel like when I put in a complaint, first of all, they phoned to ask me to drop my complaint when I'd said I didn't want telephone contact because I'm autistic and that's difficult for me. I literally wrote that. And it really felt like, so often medicine is told they should follow the methods of aviation, because in aviation, when something goes wrong, they don't blame the pilot, they blame the system, and they work to improve the system. And it really feels like the healthcare system is so broken that the only way they know how to respond to a complaint is to direct that to an individual health professional, when that absolutely was not my point at all. And yeah, I think there are so many things that need to be done to make healthcare more accessible for autistic people.
Absolutely. And I think, when you were talking through hearing, reproductive health, I think is such, a sensitive area for many. And yet it's so surprising how even more broadly there seems to be a lack of sensitivity. And you spoke about in your hospital having the kind of people who were experiencing pregnancy loss there with pregnant people. I know in my local hospital, we had a centre set up, and you went to one of two windows, one if you were pregnant and one if you were struggling to conceive. And you just think, who would design something so insensitively? So I think there's a lot that needs to be done generally in that area. And something I thought, and it links to a question that's come in, because change in the system can take a long time. And I was kind of balancing in my head, how much do we obviously do need to change the system, but because that is slow, do we need kind of supports in place for autistic people to really help them advocate? And the question's coming about whether, for example, you use a hospital passport. Do you think things like that, or one particularly in relation to reproductive health for autistic people, could be helpful, for example?
I'm glad that question's come up, because I've been working on a realist review of autism health passports with a brilliant PhD student, Rebecca Ellis, also at Swansea. And what we found by looking at all of the evidence is that there's no evidence that they're based on theory, that they're integrated into how hospitals perform. And aside from one really good example from the States, from the Aspire team, there have been no actual outcomes that are positive as a result of people using them. From working in a clinical trials unit, when you're developing an intervention and then you're testing it, you've put everything in to try and make that work. And then when they're rolled out into usual practice, they often don't work as well, because you don't have the research team inadvertently prompting people to do stuff. And so I think, what I call my cheat sheet, my allergy consultant recommended that I prepared one in case I got COVID, so I could have that there to give to the doctors if I went into intensive care or anything, so they didn't accidentally kill me by giving me something I was allergic to. And that is basically a hospital passport of sorts. And it was in my file. It went in at the first page, and then every time I saw another doctor, another page got put on top, on top, on top. So not everybody paid a lot of attention to it, even though every time I saw a new doctor, I said, there's a list of all of my conditions and allergies and stuff in the back. It will be quicker than me trying to tell you. So I think something about a hospital passport pushes the emphasis onto the autistic person. So the autistic person finds it, they complete it, they need to remember to take it to the appointment, and then they need to get up the nerve to then physically present that to a health professional. And in a UK context, that health professional will not have a lot of time to speak to you, and they're possibly going to dismiss it. If it's one that you've handwritten, they might well take it and put it in the notes, and then you've lost your copy. And I think we need to take the onus off the autistic patient and put it back onto the hospital system. And I also think it's unfair to put the onus entirely on clinicians in a system where basically the NHS is burning down and they're doing the best that they can in a really difficult situation. And I'm genuinely grateful. I had an ectopic pregnancy and I didn't die. That is something that happens to people. So as awful and traumatic as it was, and as much as it has impacted my decision to not try to conceive in the future because that was so horrible and I had subsequent miscarriages afterwards, you know, I'm alive and I may not have been. So I think in emergency care, there is a different sort of standard that people hold in terms of anything diversity related. But yeah, I think put the onus on the system, not the patient.
Well, the same person who asked that question has come back with a related one. And this links to, I think, your point of putting the onus on the system. Do you think a neurodivergent specialised midwife or care assistant, for example, would help?
I think it would be amazing. Yes. So I'm really fortunate to work with a group of neurodivergent, so mostly autistic midwives within the maternity and autism research group. And I absolutely think that if I had an autistic nurse or whoever supporting me, it's like there's a shorthand, isn't there? It's like we have a shared culture, a shared identity. They can immediately understand that I might be in a lot of pain, even though I'm not crying and whining or whatever. I've just gone very, very quiet. They might say, "Are you okay?" You know, so I think that helps. And organizations like Autistic Doctors International as well, I think have a lot of power because they are able to kind of convey what the normal bit of being autistic is, the normal experience, and they still have that status, so they will get believed by other doctors. But overall, I think if we had a system that where staff had more time and staff saw the same patients more regularly, that would have massive advantages. So a project I worked on a few years ago was around women with rheumatic diseases, so like arthritis, lupus, vasculitis, these kind of conditions where you often have very toxic drugs as part of your management. And all of the recommendations that would have given that group of patients better care around preconception, pregnancy, and early parenting would also support autistic patients, because it basically is time and the staff having kind of an open attitude to how people present.
Fabulous, thank you, Aimee. I'm conscious of time, but we do have one final question that I'd like to put to you. We've had a question come in about camouflaging and whether that might be likely to have affected participants' anxiety levels. And the question is, do you think it would be worth and beneficial investigating camouflaging during pregnancy loss? And I believe you said that did come up in your findings.
So we talked, or we asked participants if they normally mask during healthcare, and that wasn't specific to the pregnancy loss, and 61 out of 66 said that they did always or most of the time. So yes, masking is really high, and that obviously is putting quite a high burden on people. You know, because they're feeling like they need to really strongly advocate, they need to behave in ways that seem acceptable, so they don't just get pushed away for being considered a difficult patient. And yeah, I absolutely think that I would have had far less meltdowns if I didn't need to mask, and I would have needed to have masked less if my husband could have been in appointments and he could have sat and taken notes on my behalf. He could have clearly advocated, she is really not very well, this is not what Aimee looks like normally. And you know, so I think absolutely we shouldn't be required to mask, but at the moment I think the system makes us, and I think that's a really important point and something that will be picked up through the fellowship. So I'll be following 100 autistic people with wombs through up to 5 years, where they talk about all aspects of their reproductive health that have come up since their last interview, so in the past 6 months. And I definitely think that masking will be coming up clearly across that.
Absolutely. And as I said, I'm really excited about this new project. So I'm really hoping we might be able to entice you back for a future CRAE webinar as that project is further underway, so we get to hear about the findings from that work too. But just to say thank you so much again, Aimee, for such a brilliant presentation. I also just want to end the webinar by saying a big thank you to all of the CRAE team for all of their support behind the scenes, and a big thank you to everyone who's joined us. I'm really sorry that we weren't able to get through all of the questions today, but Aimee did put her Twitter handle, so I'm sure, well, I hope that if anyone has any further questions, you'd be happy for them to get in touch.
Absolutely.
Fabulous, thank you so much. Just to finish off by saying to everyone, please do take a look at our website, crae.ioe.ac.uk, where you'll be able to see details of our future webinars featuring a host of wonderful researchers, practitioners and advocates. And next month's webinar is by the wonderful Rachel Davis, who'll be talking about autism and bilingualism, and that will be advertised very shortly. So we hope to see you there. And thank you very much, everyone, for joining. Bye-bye.
Bye.